one of the locations at the Mammoth Community Health Center. So we're excited about that and pleased to welcome them into the program. We're up to 58 practices that are on the pathway to PCMH Prime, and that includes some recent additions from the Reliant Medical Group and other systems. So all told, we are now almost 100 total practices participating in this initiative. Some of them are involved right now in our TA program, and we've had a couple of events recently, including a couple of full-day learning sessions on change management and the collaborative care model, which we've been really excited about and gratified for. And we are about to start recruiting for the second cohort of technical assistants to kick off in September. So we'll be working on that and trying to identify another group of practices to go through that TA program with us pretty soon.
I was privileged to attend parts of both of the learning collaborative meetings, and they were very well done, and I think people got a lot out of them. So,
yeah. So that's all on PCMH Prime for today. We'll just focus in a bit here on the ACO certification program because the punchline is that we're getting really close to our final launch of this program. And so as we start to look forward to that, thought it would be helpful to be reminded of the steps that have been taken over quite a lot of time now to prepare for our launch together, and commissioners under your leadership to recognize the effort that's gone into this program to date. So the development of this program began some 2.5 years ago. There was considerable research and gathering of information about state and national ACO models, which included a presentation by Dr. Fisher of the Dartmouth Institute back in March of 2015. Based on those models, we began drafting preliminary certification criteria that were refined and then released for public comment in December of 2015. We had a great public comment process, continued to refine those documentation and criteria, and that culminated in the board voting on a final set of certification criteria in April of 2016. And since then, we've been undertaking an effort to draft more detailed guidance on the program, including the specific documentation required for certification, and setting up the processes for certification, including an application system for ACO users and a process for the HPC to review those applications. Now, over the past couple of months, we've put our system, a test of our system, into kind of a beta launch phase. And this included working with a couple of volunteers from among the Mass Health pilot ACOs who were willing to go through the certification process with us from start to finish, and really helped us identify areas where we needed to clarify our requirements and improve the application system. In doing so, those organizations completed full applications for certification, and those applications went through our review process in all. So, with that, I'm really pleased to announce today that both of those organizations, Community Care Cooperative and the Boston Accountable Care Organization, have met the requirements for certification and are officially HPC certified ACOs. So congratulations and thank you very much to C3 and BACO. Really want to recognize them and thank their staff who worked very collaboratively and patiently with us through the process. And it's been glitches and fixes and all of that. So thanks a lot.
So because it was beta, how much revision resulted from these two ACOs? Was there a lot of change, or just, I'm just curious.
What a perfect segue, Dr. Allen. Because I would like to take a few minutes to address that point specifically. Just to recap what the beta launch was, this process included providing the ACOs with our detailed application requirements and technical instructions, including giving some in-person training on how to use the system. We also gave them some assistance through regular group phone calls and one-on-one as needed. And those organizations completed and submitted their applications to the HPC for review. So some of the key lessons that we learned through that process In general, I think we found that the criteria and documentation requirements were understandable and, well sort of received by the ACOs, although they did have some questions. Generally, we were able to address those fairly in a fairly straightforward way through email and phone calls. The staff who actually used our application system indicated that the in-person training that we offered was helpful. That said, they all needed some one-on-one assistance at some point during the process with some aspect of the system, whether that was just a matter of how to do a certain thing or finding that the system did not respond in the way that they were expecting. And we really learned some helpful things through troubleshooting with those ACOs. We have been able to make some very specific improvements to the application system, probably at a technical level that I won't go into here. I'm happy to explain in more details if you're interested, but there were a couple of areas of the system where in particular we saw some consistent pitfalls, and we've been able to make some improvements based on that feedback.
One thing I will add is we took a lot of learnings from the RPO program in developing this platform, what worked, what didn't work, and two of the kind of key things that providers had asked for in the RPO platform, we made sure that we could make that happen in this particular platform. Those are the things that happened to cause us a lot of bugs and challenges, but that's the purpose of us doing this beta launch, and we were able to work through it and feel confident in what we're putting out.
Finally, I think it was interesting to note that both of the organizations needed a couple weeks longer than the original kind of time frame that we laid out of about 5 weeks. So that really helps us kind of gauge, as we frequently get this question, how long do you think it will take me to submit my application? I think we'll be able to go forward and perhaps guide ACOs that a couple of months may be the right kind of time horizon to think about investing in this. So we've concluded the beta process now. We've made some revisions both to our application requirements document, the PUG, and to our platform. The final draft of our application requirements and platform user guide is out now. It was released last Friday. It's now also posted on our website. And we've done the tweaks that we think we need to make to our application system. Tomorrow is our first in-person training session on the system here at the HPC, and we'll do another one of those later this month. HMA has been kind enough to offer us their space for that, so that's nice. We'll be able to do it in a slightly different location that may be more convenient for other providers. And we'll be doing a training webinar in July as well for those who aren't able to attend an in-person session or just want a second bite of the apple. And with that, we are ready to launch. I expect that before the end of this week, we will be able to announce to the ACO community that we are open for business. And with that final set of documentation requirements and the final edits made to our system, we'll begin accepting applications as soon as ACOs are ready to submit them. And we will provide ongoing support to ACOs as we did through the beta launch process through a standing weekly phone call. We'll just let people know that we're on the line and anybody can call in with questions or if they want to report technical issues, we can address all manner of things at that time. We have a dedicated email box, the HPC-certification email, which we will staff and use to respond to specific questions about certification. And of course, we'll make ourselves available as needed for more one-on-one conversations about either content questions or technical issues as they arise. So looking ahead for this first go-round, our intention is to accept applications from the date of go live later this week through October 1st. And that will give us time to review those applications and issue decisions to ACOs by early December, which will allow them to meet their obligations to MassHealth to be certified before the start of the performance year, if that's applicable to them. And then early next year, we'll really start to dig into the contents of these applications, aggregate and hopefully do some analysis of the information that we've received and begin to report out on what we've learned through the first cycle of certification. We also will be planning to implement our ACO Technical Assistance Program by then, if not before then. And we'll hear more about that in a few minutes. We may make additional improvements to our application system. Hopefully that will be an ongoing learning process, and that we'll be able to make it even easier for ACO users going forward. And we also expect at some point in 2018 that we'll be able to reopen the application period for other organizations to be certified who may not have needed to or been able to in the original timeframe.
Do you have any sense of how many ACOs are going to apply? I know that may just be such a shot in the dark, but any idea? Is this going to be 3 or 300?
Well, our estimate is based on the number of applicants that there were to Mass Health for their program, which is about 20. So we're thinking it will be likely in that ballpark. We may get a few more who are seeking certification for other purposes, either for DPH regulations or just because they're interested and think it's a good idea. And so that's kind of what we're planning for, 20-ish.
What we've been doing over the past month or two is doing outreach calls to everybody who did put in an application to Mass Health to make sure they're aware of the program, they're aware of the timelines, they're aware of the trainings. And the majority of these calls are really focused on nailing down what the right level of the organization that we would certify. If they manage their Medicaid business differently than their Medicare business, differently than their commercial business, how would you certify an organization like that at what organizational level? And that's something that we feel important to nail down before they even submit an intent to apply, because they have to put the name of the organization and the tax ID number on that application. So if they put an intent to apply with the wrong level, then we have to go back and iterate with them. So we've been doing that outreach. I think we have 3 calls left, but we've talked to almost everyone so far to just make sure that everyone's aware. What was the answer I gave? The word I like to use is every system is a special snowflake. So every system is different, and so the level of certification really depends on legally and organizationally how they've structured what we now refer to as component ACOs, which is really if you have a different legal entity or a different governance structure that governs the different types of risk contracts that you have. Some systems have many, some systems just have one.
Other questions? Thank you very much.
So we'll have Michael and Aaron and Bailiff up now.
Welcome back.
Thank you. I'll introduce them quickly, but since you guys, most of you heard from them recently, you have a little bit of context on this. As a reminder, we have contracted with Michael's company, Bailiff Health, to make some strategic recommendations to us about how to structure our ACO-TA program. We have around $2 million in funding over the course of the next 3 years. And the goals really are to promote systems in Massachusetts being able to meet the certification domains. And another critical framing point is the alignment with the district program, because Mass Health, through the waiver, is about to launch a huge technical assistance effort with a very, very large amount of money comparatively, and to be able to align and be synergistic and not duplicative, or drawing attention away from one or the other is really important to us. So with that frame, we asked Michael and Aaron to go do some interviews, do some research, and report back to us. So you heard from them last time about the kind of content of the TA. Today we'll hear a little bit more operationally about their recommendations about how to make the TA work. I will say, for context, this is a discussion. This is not necessarily what we're going to end up doing with ACO-TA, but we're really interested to get commissioners' feedback on the design proposal that Michael and Aaron have for us.
Just before we go on, can you just, I may be the only give me just a reminder about the goals for the district and how it mostly is.
Sure, there are multiple types of investments under the waiver. They fall broadly into kind of workforce support, supporting providers for payment reform, and then there is sort of the most aligned to this, which is really the ACO BizRIP bucket. And those, I don't have the slide in front of me, but I can get it to you. There are 7 domains of technical assistance that fall into that. They're broadly financial. Christina probably could tell us them off the top of her head. Fiscal, sort of actuarial support, management support, culturally competent care support. It's pretty broad and it's pretty all encompassing. And so the challenge for us was figuring out, within that, what are the specific areas for an all-payer program like our program, what is the best use of our dollars? But I can get you that exact slide. Right, so I will turn it over to Michael and Aaron.
Thanks. So this is just a reminder. I know it's been a whole 6 weeks since we were here. So we conducted a small number of interviews with 4 ACOs. Christina and her colleagues were one of the interviews we did with 2 health plans. And then we reached out to find out what was HRSA and Robert Johnson and others providing in terms of technical assistance for Massachusetts ACOs. The short answer is not much. And we also met with Mass Health to talk about their plans and solicit their feedback based on what we learned. So we shared with you some of our initial findings and recommendations in April. First, we recommended that technical assistance be focused on what we described as core competencies for an ACO. We learned that there were a number of areas in which ACOs identified a need for support. We thought with the limited funds available, you should focus on those that are most fundamental. And we identified 2 developing strategies and methods for working with data. And the second was methods for implementing care management of high-risk patients. At that meeting, David, you asked about some of the recent McMichael's research and writings, which we've considered, but we think that there's a lot of evidence suggesting that there is some benefit to effective high-risk care management of effective care management to high-risk patients. And in fact, the new issue of Health Affairs has a piece on partners and some of their success recently. So, so we picked these 2. Were there other areas? Yes, but these seem to be 2 areas that resonated with most, if not all, of our interviewees. And they seemed fundamental. There were some other topics that were identified that we viewed as a more advanced class for later on, and some that we thought were more appropriate for Mass Health funding because they specifically tied to requirements in the Mass Health ACO contract. The other recommendation that we developed and shared with you a little bit last time was how to prioritize investment, and our thoughts are to use 3 criteria. 1, to prioritize ACOs that are participating in the new certification program that Catherine just described. 2, to look at their experience, to focus resources on ACOs with relatively less experience. And 3, to look at their capacity and their resources that they have available to them to do work, and to focus on those who, again, are more in need of support. So what we'd like to do now, after, you're going to cover this one.
I think it's just another refresher that those 2 areas that Michael and Aaron recommended align very well with 2 of the SLIC 6/7 core competencies of moving toward accountable patient-centered integrated care. So we thought that synergy was great.
So what we'd like to do now is share with you details on how to operationalize the technical assistance program, and Aaron's going to walk you through a few slides with our much more detailed recommendations for how to make this happen.
Thank you, Michael, and thank you all. It's nice to be back here. So, as Michael mentioned, we identified content areas, we identified ways in which the HPC may wish to prioritize ACOs for participation in this program, but really what does that all look like now? And based on the information we gathered from our interviews and just the information from working with other ACOs nationally, we're recommending that the HPC structure this as a grant program. And there's three primary reasons for that. One is that this type of structure and design acknowledges that ACOs are at different points along experience, both as an ACO and maybe as an ACO working with different populations. It also allows for a level of customization, which was something that we heard from our interviewees that they would really welcome. And obviously it has to be within certain parameters, but really allows for customization and third, flexibility to design a program within these parameters that will work for an ACO and meet them where they are based on their real needs at the time. So this could look like grants could fund an ACO work, including any work with contractors or other subject matter experts. We recommend that each grant should not exceed $150,000 and that the grant period shouldn't exceed a year and a half. And this work should really fund, or the grant funds should really support new work only, and not previously procured or currently contracted work.
Could you just talk for a minute about those two bullets? Why did you arrive at 150,000 and 18 months? I'm not challenging it, I'm just interested in why those numbers.
Sure. So if we think that, there's about $2 million roughly to invest, and we're looking back at our content areas and really prioritizing those, these are really the foundational elements to help an ACO sort of build those basic building blocks. And then they'll have to use other investments to sustain them. And we thought that $150,000 is really a significant amount when you're thinking about developing a data strategy or developing a high-risk care management program. It's not going to necessarily get an ACO from A to B, but it will certainly lay the foundation. And then with the 18 months, we think $150,000 spending across that time period is really adequate and appropriate.
The funds are primarily to be used for planning purposes. And so in that context, we thought this was adequate. And we might have cited this example when we were here last time, but one of our interviewees said, we don't know whether we're doing care management correctly. We don't know whether we're targeting the right patients. We don't know whether we've hired the right people, and we don't know whether our interventions are right. So we're thinking for an ACO like that, to have someone who can come in and help them think strategically about how to determine who to target and with what resources to target and what interventions, that $150,000 is more than adequate to do that type of planning work. So the funds wouldn't be used for buying a new system to automate things. It's not for hiring care managers, but it's really for developing a more sophisticated, best practice informed design for implementing functions.
So who would actually do that? Who would be able to come in and help them do that?
Right. So one of our interviewees said, and it would really help us if the Health Policy Commission gave us names for people to do this, because we have no idea who it should be. We actually began collecting names. Apparently for procurement reasons, it's difficult for the Health Policy Commission to give out those names. I think they would have to go do their own networking and talk with their colleagues in other markets and find out who's best at it. But there are people across the country who specialize in both of these areas and who could provide this assistance.
So just a comment, you actually answered my question, which I was going to ask, could they use it for software, could they use it for hardware? So I think including what wouldn't be funded is as important as what will be funded.
Mm-hmm.
So we cannot compile a list of organizations that have done this for other ACOs?
I think we can talk about this more when we talk about operationalizing the program, but I think it would be challenging given procurement rules for us to do that. But we can talk about it more. It is something that we heard from particularly the newer systems that may not have established contractors who do this work with them, that they would like to know who's good at doing this work. One other thing I would love feedback on is the idea of the 150,000 cap. That means that we could potentially support more ACOs. Another idea is to have a larger cap and support a very small number of ACOs in order to make sort of a bigger impact. I'm interested, obviously Michael has recommended the smaller amount, more ACOs, but interested in commissioners' feedback on that.
My question is, so could an ACO get 2 grants? One for planning, one for data, and one for.
So what we recommend is that they can apply in both areas, but the amount wouldn't exceed 150,000. And you know, I would also add that, you know, going too small might not make it really an area or that attractive for some ACOs, given what they might be able to get through DISRIP, thinking about the application requirements and some other program requirements that might be attached to it. So it has to be significant enough to really draw the interest too.
But you're not saying that you have to get 300.
No.
But I'm asking what you think about that.
Well, it may be that we just have to go through one round and see if it was adequate or not. I think doing the beta test for the first 2 ACO certifications, we learned a lot. It sounded like we learned a lot. And this seems like a reasonable amount. I'd always rather have more people benefit from the funds than fewer. So I would say try it and then let's evaluate it at the end.
I think it really depends on what's being proposed. I mean, it feels like the right number. And I'm sure everyone will commit at 149,999. See what
So getting into some nitty gritty application requirements, just some basic details. We recommend that the HPC balance sort of the burden of applying without compromising the program integrity and the need to really monitor how the funds would be spent. If an ACO is already identified a proposed contractor at the time of the application, we would ask that the ACO submit that scope of work with the application. Again, we already talked about, we recommend that an ACO, they could apply in both areas, but the maximum amount would still be 150,000. And going back to sort of the reporting requirements and minimal burden, at the end of the funding period, the ACO would be required to submit a report that talks about how it met its stated objectives from the application.
on the proposed contractor, wouldn't we want to require that before the release of funds anyway? So not make it as necessary. You know, if they have the contractor and the proposed scope of work, fine. But if they don't, before we release the funds, that they provide that as well.
Yes, I think that would be important. And then just some final considerations. Again, we've talked about this, but it's really important to emphasize that the HPC should continue to work closely with Mass Health as it's done throughout this process to coordinate this support and the support that will be available to ACOs through the district funding. And then really communicate as early as possible to ACOs about this opportunity and what the parameters are so they can think strategically about how they might go about applying to this and also think about what might be coming from Mass Health. And to the extent that the HPC can accelerate the timing, ACOs would welcome any support, you know, right now. The sooner the better. So where there might be areas to shave off any timing and implement it sooner, that would certainly be welcome.
They really need it now because they're getting ready to operationalize in just several months. So it's sooner the better.
Okay, so I'm sorry, I need to clarify. do they have to be approved as an ACO for us first and then apply, or can they be, can go the other, in the other order?
So
And they
Michael's,
might not get approved.
yeah, Michael and Aaron's recommendation is that they be part of the program. Which I strongly agree with, because the program, as we know, we've talked about this, it's a fairly simple bar to pass to be certified. This kind of work, really anybody could benefit from this kind of work. I think the other important thing here is that Mass Health will require all ACOs to be certified with us by the operational start date, which is December 18th. So I think we will have most systems in the program. They're ready, they're getting ready, they're making the changes they need in order to meet certification. So I'm not too worried about excluding people if we set that as a box.
Yeah, we didn't specify, so what if they're in process and it's not quite done,
Right.
that's the problem.
So just to conclude with our timeline again, I hear Michael and Aaron's recommendation to get going as soon as possible, loud and clear. We have a couple other things that we're working on presently, but this is a priority for us. And so we'll work as fast as we can to take these recommendations, take the feedback from commissioners and other stakeholders to think about what a procurement would look like to get these grant funds out there in the community as soon as we can. Any last questions or thoughts about TA design? Okay. Thank you guys.
Thank you.
So I'll invite Christina Severin to come on up. Christina is the CEO of Community Care Cooperative, and I realize I didn't pick out her bio, but I think I can do it by memory at this point. So Christina Severin has a long established career as an executive on both the health plan side and the provider side. She was CEO of Bethesda Deaconess Care Organization when I worked there. For a while, and prior to that was CEO of Network Health, Medicaid Managed Care Plan, and prior to that has a lot of experience in the delivery system, particularly the community health center delivery system. So she brings an incredible amount of experience to this particular role in building a really innovative community health center-led ACO that really exists for the sole purpose of contracting with Mass Health. I got it. That's a recorder. So without further ado, I will turn it over to Christina. We asked her to share a little bit about her journey and C3's journey to becoming an ACO, and then to hopefully have a thoughtful policy discussion about what she sees as the opportunities and potential policy barriers for a community health center primary care-led ACO in the market today. Any other commentary that you want to make on the certification program is welcome. As Catherine Harris said earlier, they are one of our first certified ACOs, and it was really a pleasure working with Christina's team to get their feedback and work through this beta process. We learned a lot from them. So.
Thanks, and thanks for having me. I really appreciate it. Yeah, the certification, first thanks for giving us a certification. We're very proud of it. Since we're new, we call the company baby sometimes, so it was babies for certification. And when the opportunity came out, not only did I think it was a sort of a good idea to be able to have probably a more collaborative process as we learn together to get through it, but also given the other deadlines and commitments that we'll have rolling toward the full go live at December 18th, it kind of felt like, let's get in and get out. Go on to the next thing. So it felt like a win-win. So thank you. Okay, so this is Flickr.
Yes, that's
And this is forward. All right. So yeah, to Katie's point, what I thought I would do is kind of start at the beginning of how this came about, who we are, what we're up to, how we're approaching the work. And inside of all of that, haven't feel any questions or have any conversation that you want to. I would much prefer to have a discussion and just talk. And then leaving room at the end to just have a little bit of a policy discussion. So that was the plan. Okay. So the first slide here is just a logo view of our 13 corporate members. So you can see that we're essentially a statewide health plan. We do not have any health centers that have kind of a primary address in the central area, although 2 of our health centers are clipping the central region, Community Health Center of Franklin County on the western side and Charles River on the eastern side, so we are technically a statewide health center. As a pilot ACO, we had 9 health centers participating in the pilot, and there are 13 participating in the full ACO. And for full transparency, it was not 9 plus 5 is 13, no, 9 plus 4 is 13, because 2 left and went with the system. So it was bringing in the additional to get to 13.
Could you just talk a little bit about why some of the sort of leading members opted out?
Why 2 of those 9 made a different decision?
Or
Why there's not 1 in 13?
right.
Yeah. So, I mean, you know, I think part of the story here throughout this whole deck and conversation is that what we are doing, have done so far, is very disruptive. And what we are basically doing is taking the have-nots, who have been the have-nots in the healthcare ecosystem. I have a slide on this and kind of saying, so if, you know, if the money is here in the balance sheets and everything that goes around with big balance sheet organizations and bricks and mortar, and then you go down the healthcare ecosystem this way, health centers have been here. And what we're trying to do is say, you know what, we're gonna take them, we're gonna group them, we're gonna put them here with the other guys. And it's apparently very disruptive. And so for some of that and for other really good reasons, there are health centers who have long-standing, deep relationships with hospital systems where leaving right now felt too hard. I'll give you a really logical example. It really fully integrated with the EMR, right? That kind of clinical integration felt like it doesn't really make sense for us to walk away and we just worked 5 years on getting the system put in. Now others who were in that same situation felt like, yeah, there's some pain in making a different decision, but if we're eventually going to get there, we have to start somewhere, and this is the best opportunity we've seen in 20, 25 years. So it's kind of been, what did you say about like when you're looking at accreditation, everyone's a special snowflake? Like every health center is different and has different circumstances, and the culmination of those different circumstances really drove what decisions the health centers wanted to make on the outset of this. Okay, so I like to start with this blank slide that just talks about how this got started. So, Katie, thanks for giving the overview of my background. So, I had, my last job had been after, I was at Network Health for 13 years. It was, as you know, my Tufts Health plan eventually. I stayed about 18 months after that. And then saw a new opportunity as the first CEO of the Bethesda Deaconess Care Organization, BIDCO. So went there, stayed there for a couple of years, and it was fantastic. A lot of great people, did a lot of really interesting things. And for me, because I had spent my entire career serving underserved populations and prior to Network Health had been public hospitals, community health centers, just sort of really wanted to get back into working with underserved populations. And I think what we can talk about more today is it's really fundamentally different, right? I mean, if you're looking at a Medicare ACO and you're looking at a Medicaid ACO, and that's really important when you get down to the granular things around, you know, risk stratification and what are the diagnostics and what is going on. But anyway, so I started looking at, so I left and I had the good fortune to collaborate with the governor's office on being able to do some work at the Department of Children and Families, DCF. That was really great for all sorts of reasons, including really, for me, probably having a sophomore light bulb moment around, you know, when something is happening at DCF, when a family makes it to DCF, when a 51A is filed, when there's a bad outcome, it's kind of like the culmination of everything that went wrong, right, that DCF is left with. And a lot of times people look at DCF like, what are you doing, what's up? But it's really kind of everything that happened. And so for me, when I started looking at that, it really made me think even more about with with this population, how do you really think about systemic change? And so then we also started seeing what Mass Health was planning in restructuring, the early restructuring documents. This was before the draft 1115 waiver. And it was super interesting. So I got shared interest with several health center colleagues, and we started meeting informally. And eventually it got clear what Mass Health was doing, more and more interesting around the level of innovation. The pilot opportunity came out. We decided we were going to bid on the pilot. We needed to stand up a company to bid on the pilot. So we stood that up. It's now 501c3. It's community care cooperative. And we submitted the pilot application and we got it. So that was sort of the genesis of the company. I was employee number one. I was working off my kitchen table. It was that kind of thing. I don't know if our logo is on here, but we got our logo for $20 off of a website called Fiverr. My mother was a copy editor and my son ran copy shops. Like that was the company at that point. That was about a year ago. So we've come a long way in a year. Sometimes by the time I get to a slide, I've already talked about it, so I just skip it. I would say on this slide that we've done a lot of looking around at what's happening locally and nationally in terms of are there others doing what we are doing. And there are some other organizations doing what we're doing, a little bit in California, a little bit in Minnesota. However, we have not found an FQHC ACO network that is taking material, what I call two-sided risk surplus deficits. We do think that right now we're the only one. We've been getting a huge amount of national interest in what we're doing. We're getting a lot of calls from primary care organizations, primary care associations, PCAs, mass lead-like organizations, health center, IPAs, health centers. So, hopefully everything goes according to plan here. We're very much looking forward to collaborating on this model to see if we can bring it to other states. And, lastly on this, obviously, we're proud of what we're doing. And sometimes we say when you look at what's going on in Massachusetts and who the likely Mass Health ACOs are likely to be, we say there's a lot of apples and we're kind of orange. We're kind of doing this differently, right? No one else has organized FQHCs, and therefore we do think that gives us, some unique advantage as a starting point. Talk about that in a couple of minutes, and then also on a longitudinal perspective. When Mass Health was putting this together, we were super excited about the so-called Model B ACO, which is what it was originally called, now called the Primary Care ACO. And this slide kind of gives you the summary of why we liked it, the different aspects, and what we love about it. I'm not going to walk through all of this. And some of the things on here are also applicable to why we think Mass Health did a really awesome job with some of the Model A design as well. So this whole idea, about halfway down the page here, this what I call PCP monogamy. Just, you can't be in a Model A ACO and a Model B or two ACOs, what have you. It's kind of, from our perspective as a primary care ACO, for PCPs who practice there, they're essentially getting, for Mass Health standard, they're essentially getting single payer on Mass Health, right? So huge administrative simplification within a health center. So we really like that. For us right now, where we're at, we also like, as a primary care ACO, that Mass Health is our third-party administrator. We think it gives us a lot of nice flexibility to build this and get it dialed in before we build in any additional restraints, such as, because they're a network administrator, we use the PCC network. Our beneficiaries, our enrollees will have access to any Mass Health specialist or hospital. I like that as a starting point. I prefer not to go into this with a narrow network for a whole bunch of reasons. One of which is, I guess, going off the menu a little bit here, Katie, not speaking on behalf of the company, is I think we should just think about from a policy perspective, do we all want to march in as consumers? Do we all want to kind of march into narrow networks together? Or do we think it's okay that some populations might be marched into narrow networks while other populations might not be? And as a Model B ACO, you don't really need to cross that bridge, right? Members' choice gets preserved. Now you know, because you look at the data, that when consumers are making purchasing decisions, generally they're saying, how much does it cost? And in this program, the answer doesn't cost anything. And then the next question is, do you have my PCP? right? And for us, because the way Mass Health is running the attribution, the answer is yes. And then is it, do you have my specialist and or hospital? And for us, the answer is yes. So we thought that from a consumer perspective, that this was a very consumer-friendly model. So that's one of the core reasons why we liked it. Lastly, on this, I think the last two last things on this slide is we really liked that there was an opportunity to get into this on performance risk instead of insurance risk. One of the key reasons why we like that is because when we talked about before, sort of those who, tend to have a lot of influence in the marketplace over here and those who haven't, one of course, the challenges of going here to here is reserves and a bank account. And so the performance risk sort of shrinks what we need to do to meet our repayment mechanisms and our RBPO requirements. So that sort of also allows ease of entry for us. It didn't remove the barriers that we needed to solve to get there, but it definitely shrank them down. And then lastly, and I have a slide somewhere else in here to make this point, but as we start out, Mass Health is using about 90% of experience or historic costs to start the budget, and then a 10% of sort of average market basket price. We think that's great. It's a great starting point. And as we go through the 5 years, Mass Health says that they intend to phase out experience and phase in market. We think that that's really, we have a low cost position. We intend to build off of our low cost position, so we really like that we're not going to get rebased down against ourselves, and we'll compete against the market price.
Yeah, so, with what's happening at the federal level, are you worried, what do you think, how do you think that might impact your concern?
Yeah, so Katie knows this. My colleagues are constantly accuse me of wearing rose-colored glasses, which I do. So, so the waiver's signed. So I'm just going to echo what I believe the Secretary believes, which is that waiver is signed. And until we hear anything else, we're a go. That 5-year program is a go. If anyone wants to add anything else.
That's what's happening. If you say it will happen.
Yes. I'm not reading the slide. This is just in there for a reference. There was an article published in the November 26 American Journal of Public Health, and it studied 2 cohorts over time, total cost of care. So not primary care costs, total cost of care over time. Cohort 1 got their care in health centers, fairly qualified health centers. Cohort 2 got their care in any other type of primary care setting. And the authors studied total cost of care over time and found that over time, total spending at health centers was 24% lower than all other types of settings combined. And they also looked at quality, and they found that quality was at least as good, if not better. So that just kind of puts an exclamation point back to the prior slide on why we think our starting point is really good and why we're optimistic about our ability to succeed, particularly as this goes to having budget performance benched against average marketplace. So this slide, this is an example, right? There's a million different ways that any ACO can set up how they're going to use district funds. And this is merely how one might do it. And some wisdom in here about sort of, again, what has the general continuum been of the haves and the have-nots in the healthcare ecosystem. And so they're part of the reason why we got traction on this from the founding members and were able to start this company is because there was some fear and anxiety about kind of what would a health center's ability be to have a direct relationship to decision-making on what happened with district funds. And specifically, how much of the district would be directed into primary care medical home and other investments inside and outside of the FQHCs that the FQHCs believe were foundational to healthcare innovation on cost and quality and other things like community collaboration and social determinants of health. So on the right-hand side is kind of our model, right? Our model is very, very simple, and somewhere in here I have a very simple governance slide. the district comes into C3. C3 has a board, it's the health centers. Management presents a budget, this is the model of care, this is how we think we should spend the money, and they vote. Right, so they're not different, there's not different constituents sort of, with different views on how that money should be spent. There's really one organization making organizational decisions on what investments will have the best impact on meeting the goals of the 5-year Mass Health contract. And this is true for the pilot as well. Of course, there's no district, but this is how we are doing business in the pilot. As a governance group, we meet about 7 hours a month monthly, making these decisions and building the business.
Can you clarify, is there any investment support in the pilot for you today?
Yes. There is I'm not historically an expert on ICB funding, so I couldn't tell you how it went from what it was to what it became in the pilot. But what I know is that Mass Health was able to be flexible on how they historically use the infrastructure capacity building ICB funding, and be able to have pilots have access to that funding, particularly if the members of the pilot ACO were historic recipients of that ICB funding. And although not as robust as the district, we could not have gotten this far in supporting the organizational development efforts for the pilot if it had not been for the availability of that ICB funding. This is our vision, mission, and strategy. I will not, you guys agree, I will not read it to you, but on the bottom, the strategy kind of speaks to some of the other stuff that we're going to talk about. Like we really believe that at the end of the day, if we're going to change outcomes for the covered population, that it's got to be about community-based innovation. I'm going to talk about that. So when we sort of talk about the last strategy was vision, mission, strategy. And then we talk about, okay, and what if we're looking five years down, what is critical path and what needs to happen? Well, the first thing is that we know what the plan is with district, right? We know that it starts tailing off after year 3, pretty significantly. So the first thing that we've said is that whatever we are doing in years 0, 1, 2, 3 has to be really laser focused on having it create a plan of financial sustainability, right? Because that's our future, and that's not only the future for making this Mass Health ACO program work for the 5 years and beyond the 5 years, but this is also something like we see this as a really, really big first step in really changing the innovation of these health centers. And when we create financial sustainability on this first population, this very large Mass Health population within health centers, and we can beat our cost of care budget and we can bring these costs down, that then creates the opportunity to take it to the next population and the next population and the next population. So there's a real imperative for financial sustainability for many different reasons.
How much do you need to lower the cost of care by to make it work?
It's a really important question, and I don't want to get it wrong. So it would be, the really basic math would be how much do we need to lower cost of care to replace the district dollars and create savings on the additional dollars needed for the additional investments? I can get back to you on that number.
Is it something like 5?
Yeah, I would say it's probably something like 4 to 7%.
4 to 7. It's not like 20 to 25.
No.
Can you give us a sense of your estimated lives in the full program versus
Yes.
lives in the pilot?
Yeah, so I think right now we have approximately, it changes a little bit month to month, so approximately 34,000 covered lives in the pilots. Our best estimate on the full program is somewhere around 100,000 covered lives. So it's interesting to think about it, and let's say 100,000 covered lives is somewhere between, on a total cost of care risk budget, somewhere between $400,000 and $600,000. it's a big company to kind of turn on overnight. So we don't really have time to talk about this today, but you'll see in some of the slides what we've been working on. Like, we're not waiting, right? And we've developed partnerships I can talk to you about, because we are in full implementation. You know, of course we're assuming we'll get a contract award. We don't know that, but we feel like we can't wait to find out that definitive information, or it will be too late to get to the readiness that we want to have for December.
I told you, 47% of $400,000 to $600,000 doesn't seem like that much money.
Oh, it's also where you beat your budget and how the budget gets set based on where you are against market over time, and how much in the beginning with the risk corridor is over time.
Those who are complicated games with the memory.
That's why she said you get that too.
All right, because the math I was doing in my head was 500,000, 5% of that was 25,000. Right, so if you said, I was going to say 5%, I say 25,000, that doesn't seem like it's enough to support an organization or any investment or anything. And so I'm probably missing some part.
Yeah, look, can I follow up with you?
Absolutely.
Awesome. Which I have the CFO here.
I wish I knew more about finance than I do.
We have modeled it, so I can definitely
No,
follow
no,
up
I'm
with
sure you have.
Yeah.
I'm just trying to understand what I'm just.
Okay, so on this slide, let's talk a little bit about what we're thinking on the model of care. Is really thinking about in my experience working at Boston City Hospital, health centers, network health, etc., that when you think about, let me say it this way, this is how I sometimes say it to people, and you know, I think this is apropos of the work that Michael Bailiff does too, is if you came down from Mars and you looked at the reports that we have, that we run ourselves, or that Mass Health gives us, they've done a spectacular job at creating these reports in the pilot period, provider summary reports. I could be watching that title. And they give you lots of really, really good information, including kind of, these are the key characteristics of the top 5% of the population, the next 10%, I believe, or 15%, and then the remaining. If you came down from Mars and you looked at that and you said these are the key characteristics from diagnostics, you'd say, well, this is a behavioral health organization. There is some asthma on there, and there is some diabetes on there, and there's some heart disease, but it's really small compared to the issues around mental health and substance use disorders. And so, what we want to do, and you guys know this because you're experts, is one of the issues is, not the only reason, but one of the key drivers is that you're living in poverty for 5 years, or 10 years, or 30 years, or 50 years. It does tend to drive through the chronic stress and chronic trauma. It does tend to drive a lot of morbidity with regards to mental health and substance use disorders, and certainly other conditions too, like heart disease and diabetes and hypertension, for example. And so one of the things that we want to do as a starting point and over time is to say, since we know that, can we try to create a model that is not a traditional medical model? I mean, certainly if somebody has diabetes and they want some help improving self-management, we will deliver that, and we want to deliver that really well. But zooming out, thinking about sort of what is really going on here, and therefore what can we do as an ACO, as a primary care medical home, and how can we develop innovative collaborations with schools, with the Department of Corrections, with DCF, with all of those kind of sort of interagency, public-private partnerships to think about what is it that we can do working together that sort of ultimately, if we treat something here where there's a pathology around the morbidity, and then we get it here, and we get it here, and we get it here, and we get it here, that from a longitudinal perspective, hopefully together over time, we can start preventing the development of some of these conditions. That's sort of our most aspirational view of what we would like to do here over time, and part of what we are planning from a nascent perspective for the model of caring for Go Life.
I'm just going to say as a pediatrician, yay. I mean, adverse childhood experiences we know have very long-term and intergenerational effects, so what you're doing is addressing those.
But that,
Right.
but that's not gonna get you 5% in 3 years. Right.
So, well, you know, one of the things I would say from a policy perspective, and this might not be necessarily an HPC thing, policy perspective, but I think it would be a Commonwealth of Massachusetts perspective is, over the long run, how do we want to value work like that? And if there's really good work that's being done, that's delivering incredibly positive outcomes that we can measure, and they may not be cost of care outcomes, how do we value them?
Could you just to really build on David's serious question, kind of talk about your early thinking for how you will do this? I mean, it's really helpful to see what you want to achieve, but we all know it's not easy to do, and none of us really knows how much it costs to do it well. So in forming these partnerships, can you just give us a couple of examples of what you might tackle and how you might go about that? That just would bring it to life a little
Yeah,
bit.
I'll give you two examples. One that's
And make sure they save money.
Yes, yes. One, I'll give you the first example that's sort of less aspirational, but more like what we actually achieve for Go Live, right? And then give you a longer example. So the first example would be having a way to screen and address social determinants of health, just like we would for physical health, including having technology that supports the screening. If something comes up, technology that supports addressing it, or what we call sort of a fulfillment against that need, and having a way of measuring the outcome of that fulfillment, and have that be integrated with the full ACO enterprise technology solution, which I'll talk about a little bit today. Even that won't be perfect from day one. It might take us a year to get to perfect integration, but to have a systematic way to do that. And of course, you know, again, sort of a shout out to the state in thinking about flexible spending, because that's definitely part of it. And just as a refresher, I know that you guys are experts, is that every ACO will get an earmarked, a dedicated money every year, PMPM, probably somewhere in between 350 and 4.25 PMPM. For flexible spending. This is part of the 1115 waiver approval. That money needs to be specifically spent on social determinants of health. Those issues need to be documented in the care plan and part of the care assessment and care plan and ongoing monitoring. And it is a use it or lose it on an annual basis. So that also what the state has put in on flexible spending really had our plan come together on purchasing a solution with this and getting it integrated into our enterprise ACO solution. So that's a first sort of easier, more concrete example. I would say, and I was gonna talk about this at the end around sort of for you guys and policy ideas. I don't know if this would be again HPC space or Mass Health, but thinking about right now, there is some good collaboration in between organizations like a DCF and a health center. But are there ways, I'll give you two examples. One is if a family is currently getting some sort of support from DCF, is there some way through HIE where there can be, if the family is also a member of an ACO, is there a way that somehow the goals, for DCF's goals for the families with proper permissions, of course, could be integrated into the care plan, right? And that might be, would there be an aspect of physical health perhaps, but that also might mean integration with behavioral health community partners, because there could be involvement from a mental health organization, for example. So thinking about when we think about getting to where we want to get with community-based collaboration, one thing we think about is what can happen from a policy perspective with regards to HIE around some of this stuff. And if we think creatively about HIE, is there a way to fast track this and streamline it while at the same time making sure that the proper privacy protections are in there for consumers? You know, another random example would be, you know, schools. So what currently is the relationship between a family and a health center or any primary care setting and a child who may have an IEP or who may not yet have an IEP, but we know isn't reading at level in first grade, for example. And is that a school problem, and do we let that be a school problem? Or again, is this potentially an opportunity to collaborate and say, we know that when someone is living in poverty and not reading at level as a 6-year-old, for example, it could be an indicator, that there may be, that might impede the child's chances of success over time. And is there something that can be done when all of the members of the community or some members of the community come together and say, I'm not just going to own things that are about clinical pathology, and you're not just going to own things that are about reading, but we're going to try to support families together.
And I would just say, I would guess that some of those interventions are very inexpensive, actually.
Right.
To collaborate with libraries, you can get books, and you can do language training, there's all kinds of things you could do that are not expensive.
I'm just reflecting in my own mind mostly, which is that earlier Michael said, we think the biggest short-term competency that ACO should develop is management of high-cost cases. And now you're saying, well, gee, we think the biggest short-term capacity we should develop is community-based outreach and integrating health and social conditions. Both of those strike me as good statements, that are statements I agree with. And there's some overlap between them, but it's not complete overlap between them. And so I'm just sort of hearing different philosophies about this and wondering, how do I square those in my mind?
Yeah, I have one thought that I'll just add before Christina answers, which is Michael and Aaron's recommendations are really from an all-payer perspective. Clearly addressing social determinants of health does apply to a broad population, but it is critical to do that for a Medicaid population and to make money in an ACO model so I think that may be a reason for some of the difference between really honing in and focusing on and that's actually the feedback that we got when designing the ACO certification program, where we had a couple standards on community-based interventions and addressing more social determinants of health. And the medical care community, said that was too high a standard to hold them to for an all-payer voluntary certification program at this point in time. So that just might be some context.
So I think for us, they're incredibly complementary, and we are doing both. So we have planned a very comprehensive program around predictive analytics technology, rules-based engine to adjudicate workflow for high-risk care management, the top 5%, whatever you want to call it. And we kind of think almost in the broadest sense on the model of care, the broadest sense. There's kind of two buckets, right? There's that top 5% and there's everybody else. And let's call everybody else population health. So there's really, those are the two very complementary items. So in that top 5%, you might pick up a child who has stratified at the top 5%, who also might have an IEP and could use academic support, or in the remaining roughly 95%, you could pick up a child who's relatively healthy from a physical health perspective and has an IEP and needs academic support. So I think that they're not at odds at all, and they're very complementary and come together nicely in a model of care. One other thing on this slide, the second to last bullet, is that one of the other things that's in scope for us is that the clinicians who work at health centers are amazing. They're amazing. They come to work every day, and I know that this is true. Clinicians are amazing people, period, right? And they do what they do because they love it and they're passionate about it and they care about people. At the health centers, it's particularly challenging, right? Resources have always been constrained, salaries are constrained, everything that goes along with that. I'm married to somebody who is a family doctor at a health center, and at night, after he's been working all day at 11 o'clock at night, I see him starting on a pile of paper that's this big. Like, oh my God, what are you doing? And it's VNA forms and disability forms, and it's like, So there's got to be a better way. And within all of this and within this implementation, critical path is also saying, what are some of those things that are impeding PCP satisfaction inside of PCMH or inside an FQHC today? And how do we put that in scope for implementation so that as we ask clinicians to do things differently, sometimes now to do something extra, to have another team meeting, how do we also say, and we get it, and we are trying to make your day better? So that's really important to us as well. Just taking a quick look at this to see if there's anything we have not talked about. I think that I'm gonna move on from this slide. Katie, if that's okay with you, because I think we've talked about it, unless there are any questions, of course, on this slide.
Just a quick one, kind of toward the bottom of the slide 33. When you were first beginning this, you said ultimately you'd love to take it to other states, kind of make this a national effort. And you allude to this sort of locally and nationally. Kind of what are you thinking in terms of you're meeting your own milestones, timelines, kind of for those of us on the committee who do work nationally, and how should we think of this in our own minds in terms of advertising what you're doing?
Yeah,
Is
so I
this a
think,
3-year project, 5-year project?
I think all of the above. It's a journey, and I think some of the troubleshooting that we did to get to where we are, in my experience now, having spoken with people nationally, health center IPAs, is that other states have not necessarily figured out how to remove those impediments to getting here. So I think there's already things we've done in forming the company that could be really useful to other FQHCs or interested parties in thinking about getting this far. And then, and also in terms of what we've already built from the ACO and how this is all going to adjudicate as a system. And then I certainly hope as we go along, we'd be able to say, these were successes in year one. This is what we think we drove our success in different areas on social health, on physical health, on behavioral health, and then more of that as we go on 3 to 5 years. I also think that there's so much to be learned from what Mass Health has done in setting up the architecture of the Mass Health restructuring, that it could be really informative for other state leaders or other stakeholders who are interested in this kind of work when states are looking at just reviews, 1115 waivers, or even what the state is able to do in terms of this program design, and specifically how Mass Health created an opportunity to preserve the ACOs that were already in the market, but also to remove barriers for organizations like us who are interested in coming into the market. This is super simple, and it really just says that every corporate member, every health center comes in as a corporate member. Every corporate member has 2 representatives on the board, which is the CEO and the CMO, as long as the CMO is practicing PCP, which they all are. And then you can see there's also the consumer representative and the CEO of the company. And then you can see that we have these committees. So in between all of this, as I mentioned earlier, right now we're meeting 7 hours a month. There's obviously a lot of work to get done and a lot of decisions to be made.
Are there patients on the patient and family advisory?
Yes.
And just as a reminder, that is a requirement for certification that you have a consumer in the governance structure and
What I would say about this slide is one of the things that we did to have this work for all of our health centers. We have a broad diversity of health centers. We have some large health centers like Lynn Community Health Center, East Boston Neighborhood Health Center, and then we have smaller health centers like Community Health Center of Franklin County. And we wanted this to be an organization that could work for all of them and sort of meet them where they were at on the continuum of experience managing in an ACO environment or similar ACO environment, like managing a PACE program, and also for those who are more nascent in these efforts where C3 was going to be their first experience. So we did not create sort of what we call the IFAs is jargon for, we have a contract with Mass Health, and at the end of the day, we're gonna get a surplus, we're gonna owe them a deficit. That's pretty straightforward. The IFA is a very complicated system that says, and within C3, what are all of the puts and takes on financial performance, cost and quality performance at the level of each of the 13 health centers. And so we created 3 flavors of the IFA within the organization in order to accommodate those who are smaller and who are newer in this versus those who had some experience this and had the balance sheets to support more risk directly being given to that health center. And then what we did further is sort of pair the level of what we call care management delegation to the health centers that are signing up for a higher level of risk, where the lower tier health centers with less experience were saying, you know what, the model of care is the model of care, delegation or no delegation. The financial support is the financial support, delegation or no delegation. But for those who are starting out on this journey, we're kind of going to directly support you more. And what that would mean as a practical example is if we hire an RN for complex care management for a low risk health center, that person would have a job at the health center and live at the health center, but they get a payroll check from C3. And for a high risk center, they hire the same person into the same job description, and they would receive a check for C3 to support the person getting paid on their payroll. So just to say that because we have a diversity of health centers, we didn't create a one-size-fits-all model. And our hope is that when we go through this journey, that everyone is able to move through this continuum.
And just to add one point, commissioners, the way that ACOs distribute surpluses and deficits in terms of to their subcomponents is something that we did ask for in the certification programs. It is proprietary in many cases and will be held confidential, but when we think about the certification program on an aggregate basis, we're going to have tremendous insight that we don't have today, and how different organizations are thinking about the distribution of funds under these types of budgets. And I think we'll, over time, really be able to provide some insight in, are there best practices and ways that organizations should think about supporting and incentivizing through those types of fund flows constructs.
But I would commend Christina because she is actually out there publicly with hers, unlike unlike most other systems.
Yeah, I mean, one of our guiding principles, I don't want to say I would tell anyone anything that we're doing at any time, but one of our guiding principles is that we're in this for the common good, right? We're all in this to support Mass Health beneficiaries. If there's something that we're doing that works and can be helpful for somebody else, we want people to have that information. We don't feel like that's competitive or proprietary information per se. So we're happy to share.
Is the risk all borne by C3?
Sorry?
Is the risk all borne by C3?
So C3 bears the risk by holding the Mass Health contract, and C3 subordinates some of that risk through these 3 risk tiers. So this is, I know, a super well done slide. It's the main brain. Is the point here is we're building an electronic data, a enterprise data warehouse, an EDW. That's the main brain. Our EDW will be fed with structured data elements from patient screens, a positive screen on a social determinant of health, for example, all of the EHR data from our 13 participating health centers, social determinant of health data, Mass Health claims data, and ADT information. I'll talk about that more in a moment. All of that goes into the main brain, the EDW. So think about it as a warehouse. And you walk up to the warehouse and you open the door and you walk in. And what you see when you walk in is shelves. They're very, very tidy. What you have on the shelves is structured data elements. So there's EHR shelves that have BMIs and blood pressures and different elements that came out of the EHR, all of the structured claim information, etc. And then we say, great, shut the door and you walk out and you say, all right, now we're going to run the business off of that warehouse. And so we're going to run predictive analytics, for example. And the way that we run predictive analytics is saying, who are those individuals who we identify as being at risk for a future adverse outcome where an intervention would make a difference? We couple those two things. That's on the left-hand side, complex care. And you can see these other things, again, running a stratification around likelihood of readmission, social care needs, and then population health, gaps in care, et cetera. And all of our financial reporting we do off of this. All of our business intelligence, performance analytics. So that all goes off of the main brain. We have a partner in all of this who is Evelyn's Healthcare. They are headquartered out of Alexandria, Virginia. Don't quote me on Alexandria, but it's Virginia. And this is their EDW. What I wanted to say, happy to take any questions that you have. I also wanted to talk a little bit about ADT feeds, and this probably also fits into the HPC policy domain. Is that, so we've been on an ADT quest. An ADT is a jargon for admission, discharge, transfer. It is when somebody when someone registers at a hospital, moves around at a hospital, or is discharged from a hospital. Technically, it doesn't have to be a hospital either. When we talk about it, we're talking about hospitals. We were also talking about a notification, right? And notification that somebody has registered in an emergency department. It doesn't have clinical content. It's an electronic notification system in ENS. So we've been on this quest to get ADT feeds. Why? Because we want it in the main brain. Why? Well, because if we have somebody in complex care and she registers at the emergency department, we want to know, we want to be able to appropriately share the information. If we have somebody admitted, we want to know because we have a transitioning care program. So really critical path information. We started speaking with hospitals about this, and we started speaking with MAHEC, the Massey Health Collaborative, and discovered that they're actually doing some of this work already. And so we have been working in a conversation so far with 5 other ACO systems who are part of the pilot and thinking about, could MAHEC potentially be a clearinghouse solution for all Mass Health ACOs? So essentially, we would create a shared send and receive ecosystem of these ADT feeds for any MAHEC participating ACO. I'm not quite sure yet if everyone will be interested and pursue it. I hope that they will, and I think some of them definitely will. And from a policy perspective, this is something that the state seems interested in. And I know that, perhaps you guys have been looking at this. So I want to let you know that we were looking at this too, and it feels like we're getting some traction. And if there was a way that we could work on this together, then that would be really great. Kind of ditto for the SDOH data. So as mentioned earlier, we have purchased a sort of a technology platform solution that will get integrated in this schema. It has a crowdsourced knowledge base. So if a community health worker sends somebody to a food pantry and finds out that they closed, that information can be crowdsourced into it so that everybody knows and it's updated. If there was a way, so we're building it, but we don't necessarily need to do that. And if there was a way for us to come together to try to build a knowledge base or resource directly together in a way where the structured elements could support the different technologies that people are using, that would be great. Again, for us, standalone technology doesn't work because we need things to be integrated to get into the warehouse to adjudicate the model of care.
Maybe a question for Katie more than where is this data?
The community resource directory.
Well, and the ADT.
ENS. The ENS is easier to answer. The EHS through the highway team has a plan to procure an event notification system and admissions discharge transfer process, but it's a little bit later than probably Christina would like. So it's sort of a 2-year horizon to procure a vendor to be able to do this. Mass Health is also contemplating, I think the biggest challenge here that Christina could also probably speak to is hospitals' reluctance to send their feeds through this. Every ACO has had patient paying since the beginning of Pioneer. They refuse to share their feeds with each other, because of competitive information. And so I think there are some regulatory changes that EHS is thinking about making to require hospitals to send feeds, and also procuring some pretty basic technology. And if the provider systems want snazzier versions of it, then they can add on to that.
And we've been really heartened by the level of support that we're currently getting from the other Mass Health Pilot ACOs, at least in their nascent interest in all participating with MAHAC together. I mean, again, I don't want to speak for them, and I don't want to speak for what decisions they'll ultimately make. I just want to say that, right now there's a really good spirit of collaboration on this. We've kind of already talked about this and kind of that both are relevant, both top 5% and then everybody else. I'm gonna skip this slide unless anyone has any questions. So, I was going to talk about the ADT stuff. We've talked about that. The community resource directory, we've spoken about that. I wanted to talk about something else, and again, I'm not sure whether this might be of interest to the HPC. Thought I would mention it. Another opportunity to say kudos to the state around thinking about the behavioral health community partners and also LTSS community partners. We really love it, and we're very supportive of those community-based efforts. One thing that we do worry about and hope to find a way to solve is kind of how do we, where the rubber meets the road, how do we actually get all of the information flowing from ACOs to behavioral health community partners? We've purchased this solution with Evelyn. It has a cloud-based care plan, but do behavioral health community partners want to use our cloud-based care plan? Because they'd have to use every ACO's cloud-based care plan. We could use assistance in thinking through how the state envisions this and how the state might have a role to support sort of the infrastructure and the data sharing and the moving pieces around this. Because I think that from a policy perspective, what the state has done around the BHCPs, LTSS is great. And I think that it will really deliver on the policy promise if we're able to share information in a way that really creates collaborative care. So I don't know if you guys might have any thoughts about that, but I wanted to share that. And then anything else, I am not an expert on HIE, but getting back to kind of what happens in the day of the life of a PCP, if you have any other policy ideas or if there's any policy ideas to be explored around, is there an opportunity to use HIE to eliminate administrative paperwork? And I guess I'd say particularly any sort of interagency paperwork. Are there any HIE opportunities around that? I don't really have any great ideas because a lot of the ideas that I can think of would not necessarily be intergovernmental agencies, but more members of the private sector throughout the care continuum. But to think about, in all of this, is there a way to bring more administrative simplification for primary care clinicians?
I have 2 cents here about administrative simplification. I think this is a huge topic we should be discussing at our cost trend hearings because it impacts all providers. My one concern about HIE is accuracy. Because as a patient, when I saw what looked like it was in the system, it was totally outdated and wrong. So you don't want bad information. And how do we prevent that? I think that's one of the questions. Yeah.
Just a very small question on the administrative stuff. Most of the QHCs are mostly doing mass health, right? So it's not that they're getting, that they have to deal with 17 across that's 27,000.
They probably have as many carriers. The number of patients enrolled in those carriers just becomes quite small when you get down to an Anthem or a Cigna, more significant with Tufts Blue Cross, Harvard Pilgrim, and Medicare but certainly the largest covered population is Mass Health, absolutely. And with our 13 health centers, I think that ranges on the low end from representing about 20% of the patient population to 55-60% of the patient population.
So I'm going to jump in with a question, Christina. First of all, thank you for participating in the ACO program. And I think, just to reflect back to the commissioners, when we were designing this program, one of our key principles was allowing for different types of ACOs to participate in the certification program and not to have a kind of, this is the one size that everyone has to meet. And having a system that does not include, an acute care hospital as one of its core members is different than many of the other ACOs that are developing. So I think we hit the mark on that in terms of being able to have some flexibility about organizations coming together. I guess I'm interested in you reflecting a little bit about, you have community health centers across the Commonwealth, and how you're balancing a need and a desire to do some top-down standardization about how these different organizations are implementing these programs, putting interventions in place, and also reflecting that they have long-standing community ties, long-standing histories, in some ways their own way that they want to do things, and to add to that, even off of the clinical side of it, you mentioned how much community-based partnerships are critical and essential, and I'm wondering, what is the ACO providing in terms of support to those individual members? Are you kind of just telling them, go out and do this, but we're not going to necessarily handhold your way through that?
Yeah. So, firstly, one of the things we say is that historically there's been a slogan that is, if you've seen one health center, you've seen one health center. And what we say is, if you've seen many health centers, you know that health centers have much more in common than they have that it's not in common. And when we come together to leverage our commonalities, we all do better together. We have one model of care. And we do not say to a health center, yeah, all right, you're a little bit different, so you don't have to do this model of care. You can make up a model of care, you can significantly alter the model of care. What we say in 13 different conversations is, we have one board-endorsed model of care. What we want to talk about is localizing and implementing this model of care in a way that makes sense for your health center, because every health center has unique things, whether it's serving more kids or less kids, or different immigrant populations, or people who speak different languages, or different models of MD heavy model versus an NP heavy model, like those, current capabilities, how much we need to build out for them, how much they've already got that we can support. So I would say that you would probably be surprised at the level of insistence on consistency around fidelity to the model of care that we've designed, and the details that we have around that model of care, down to job descriptions and staffing ratios and leading and lagging indicators to measure that model of care, while at the same time having the health centers feel like we're being reasonably flexible. And I'd like to also think that they would say the areas where we're not willing to be flexible is actually better for them and better for the collective. An example might be in high-risk stratification. A lot of times, and this is not a health center unique thing, but a PCP might say, that member on the list, that patient on the list doesn't really need complex care management, but I know somebody else who does, so I'm going to scratch that one and put that one on. We say, now, we're running the science, and if you feel like there is somebody who should be included, please let us know, because we want to research it and see if it was a miss. And if it was a miss, meaning they're at risk for a future adverse outcome and an intervention would make a difference, we will gladly add them on.
Very interesting.
In your work in the central nervous system part of this, as you, the brain, exactly. As you look forward, what are the 2 or 3 sort of fatal landmines that you can think of now, or that you all have discussed, where policy changes could make a difference? So kind of as we and the commission think about what do we need to be paying attention to make your model be successful, where do you see, oh my gosh, this would just do us in, and we could change it? Katie mentioned some of the regulatory issues, the competitive issues. And what have you thought about in that realm?
So, I talked about some of the things that we think would support our work, like ADT, for example, and the Community Resource Directory. When I think about kind of what could really cause a red light, I wrote down a couple of ideas. I'm just trying to think how would that translate to policy, but you might have more wisdom than me on that. So workforce, is definitely ability for us to recruit and retain everything that's needed to support PCMH and now all of the additional requirements around the model of care. And that's part of why we think improving work life is so critical, recruitment and retention. So if there's anything that could be done to support that, and that's true not only, of course, on PCPs, but LICSW, community health worker, peer support, psychiatry, particularly child psychiatry, all really, really important to us. I think that, because health centers have tended to be under-resourced organizations, they haven't been able to make investments over time in some of the sort of organizational capacity around some of this change management. So an example would be, they haven't had the scale or the financial ability to invest in really, really robust leadership programs. Succession planning, change management, but not like around the perimeter, like really invest in that and really build the management capabilities. How you get that out from a policy perspective, I'm not sure, but I was definitely thinking about it when Michael was talking about, his thoughts on what could happen on a moving forward basis. We think a lot about when we get 13 CMOs in a room, which we do once a month, and they talk about, we talk at them sometimes, and then sometimes they get to talk with each other. And some of the most powerful moments are when they get to talk with each other. And so, for example, in pilot, we'll talk about our efforts on engaging a top 5%. I don't know why I would say top percent. It's never exactly 5%, the top percent. And they start talking about, well, how did you use that community health worker? Like, how did they do it? How did they get it done? How did that individual actually get engaged? And it's really when they're in that environment with like what I call peer-to-peer learning, it's really powerful because I think a lot of times, I don't know if this is true everywhere or if I just see it in health centers, there is a lot of support for training. The training modality tends to be come to this location, we'll bring people in, and they'll train you. It's good, right? There's some of that that's really valuable and it's really helped over time. But I think where we're at now is really, they have so much knowledge when you put them all together. It's really, how do you leverage that in a peer-to-peer environment as we're really like hands-on implementing this work? Because we see is really a critical need.
A good recession always comes with workforce issues.
Good recession.
I'll ask one more question. Thank you. You mentioned that the members who are going to be attributed to the program are going to have access to the full suite of specialists and hospitals. Obviously, the spending there contributes to your total cost of care. How much are, you said you had one clinical model that you are putting in place and kind of requiring the health centers to follow that. Are you putting in place guidelines for them in terms of who and how they refer patients to specialists and to which hospitals?
So in terms of referral relationships, our starting point is preserving existing relationships. And it's not, there are very deep relationships. It's not equal across the board, but with some of our health centers, they've been doing primary business with an acute care hospital for decades. They have, clinical integration. There are a lot of assets. All of the staff are credentialed at the hospital. So we don't want to, one of our principles is don't break anything. So in something like that, we're preserving those relationships and we're saying we'd like to now hire people and put them at that hospital because we think that there's a lot of value not in doing which we're not permitted to do anyway, but in being able to meet the patient or the family face to face to understand and perhaps assist with discharge planning, particularly removing any impediments to safe community-based discharge planning. And then having gotten to know that family, when we show up or peer support specialist shows up after the discharge and we ring the doorbell, we are more likely to be let in because we created a relationship with the individual who was bedside. In terms of total cost of care, unlike the commercial environment, because this is mass health pricing, there's more normalization. It's not exactly, but there's a lot of normalization. So out of the gate, we're really not thinking that a strategy for cost containment is changing relationships. We are really thinking that the relationships that we have are assets coming out of the gate, and we want to deepen those relationships and think about new ways to work together, particularly bedside and particularly in the emergency department.
I agree with that, but one of the things we've documented a lot at the commission is, for example, use of post-acute care services varies enormously across hospitals. And so that does seem like an area where not to force people to do the institution, but to monitor that and see, gee, why is it that in some areas of the state where patients with X are going institutionalized post-acute, in other areas of the state they're going home. Seems like it would be a fruitful area.
Absolutely. Absolutely, and that is in scope for the program, the bedside program that I was describing. We call transitions in care, and that is one of the key objectives in the work of the individuals in those roles is the discharge planning and saying, initially, if the hospital is thinking there's a plan on post-acute care, is it the most community-based and safest plan? Are there things that can be done to remove impediments to adjudicating something that is home-based or more community-based? And then as we move down the road, we would like to look at the data you're describing and then make decisions about continuing the work on discharge planning, of course, but then saying, okay, can we make decisions about preferred post-acute providers?
Great.
Thank you. Thank you all.
Thank you very much. Very exciting work that you're doing. I'm pleased to be part of it. Are there any other agenda items anybody wants to bring up or comments before we adjourn? Our next meeting is July 9th.
And we have a board meeting next week.
And we have a board meeting next week. Thank you very much.
Yeah.
So this week, you all yeah, I am too. I figured